been a long day. Thank you for those who are standing on board. I think we'll leave the best for the last, and that will be Dr. Abu Anin's part. I have a conflict of interest because I've done more ileal ureter than auto transplant for urethral stricture disease or urethral trauma. But I'll try and see if I can convince you for renal auto transplant in select cases. So, if we go back to history, in the late 50s, a 58-year-old gentleman presented with a severe atherosclerotic disease of his aortoiliac, and he had a grafting done. And then a couple of years later, he presented with a ruptured infrarenal AAA. So the surgeons took him to the OR and they did a AAA repair. And then 3 days later, he was basically peeing through his drain. So they took him back to the OR and they discovered that when he had his original aortoiliac grafting, they had transposed the ureters behind the graft. So that when they went in to repair the AAA, they didn't recognize that the ureter was behind the graft and they nicked the ureter. So they did a UU initially and it failed. And this was their original description in 1962. And then James Hardy proposed to do a renal auto transplant for this patient. So they did a nephrectomy and then they auto transplanted the kidney onto the iliac artery and vein and urethral neocystotomy, and the patient did very well. And this was the first officially reported successful outcome. So in essence, basically, you when you're doing a renal auto transplant, you basically do a nephrectomy. You flush the kidney, prepare it, and then you auto-transplant it into the patient's ipsilateral or contralateral iliac fossa, just like you would do for an allo transplant. Basically, the principles are that in addition to, if these cases are being performed for urethral disease, they probably have percutaneous nephrostomy tubes. You want to make sure you get rid of that because it's a potential nidus for infection. You want to keep these patients on aspirin for 3 months and antibiotics maybe for 1 to 3 months. And then you'll annually follow up these patients with ultrasound Doppler to make sure their grafts are perfused. So before we embark on auto transplant for urethral indications, really the success of auto transplant is mainly, and I have to say this in complete honesty and with a grain of salt, as they say, it's really very strongly indicated in renovascular diseases, and that's where the success of renal auto transplant stems from. So if you look at renal artery diseases, renal vein diseases, that's where the majority of the success of auto transplant comes from. You can obviously do it for other causes, such as RPF, complex or intractable stone disease, and some oncologic cases. If we look at the outcomes for auto transplant for renovascular indications, so this is mainly renal artery aneurysms and AV malformations, they do extremely well. The success rate is above 90%. In the long term, they have preserved renal function. But the important point is here is that you have a healthy ureter when you're anastomosing it. So you're not really dealing with a higher risk of urologic complications so much as vascular complications. So from a urologic standpoint, auto-transplantation for renovascular diseases carries very little urologic risk. It's mainly vascular risk. And these are case series from the 70s up to the modern era. If you look at the outcome for renal venous diseases, so renal auto-transplantation for nutcracker syndrome, renal auto-transplant, in many expert opinion, is superior to renal vein transposition and to renal vein stenting. It has the longest outcome series in terms of follow-up. So again, the victory of auto-transplant in these cases cannot be completely identical to what it is with urethral disease and intractable stone disease. So I can embark on my personal experience with this, with renal vein diseases and renal arterial diseases. So we used to get a lot of these cases referred to us for renal auto-transplantation after renal vein stenting and after coil embolization of the gonadal vein. And these patients would mainly come to you with pain and some with hematuria. And honestly, the concept of taking the kidney out, denervating it completely, getting rid of the stent or the coils, and auto-transplanting it in the pelvis does help them a lot in terms of pain when the pain is in the flank mainly. But when there's pelvic pain associated, it doesn't really help much. So in terms of managing pain for these challenging cases, and you can see this is a case that we had to deal with where the renal vein stent was actually poking through the vena cava. And you basically treat these cases very similar to how to treat caval thrombus cases with RCC. You have to control the cava completely, and at some instances even patch the vena cava with bovine. So this is a case I had to deal with multiple gonadal coils, and that's also another irritating factor because a lot of these patients get coil embolization on addition to the renal vein stenting, and that's very challenging to deal with. Before we go to the stricture disease, another solid indication is in very select cases of intractable metabolic stone disease. So we're talking about patients, this is a cohort of patients from the Cleveland Clinic. And if you look at this cohort of patients, they're really young patients. They have a lot of stone events. They have multiple procedures performed in the past. So we're talking, some of these patients have had 30 procedures. Some of them have had 50 to 70 visits to the ER. So these cases will potentially benefit from an auto-transplant for many reasons. One, you denervate the kidney, you get them off narcotics. Two, is you create a shorter passage for them. So they can, if you do a pylovesicostomy, for instance, with this, or a Boari flap, they can pop the stones directly into the bladder and you can deal with them. Or if you do a urethral anastomosis, then you have a shorter segment of ureter to deal with. Looking at the results here, 92% of these patients were off their narcotics. Their renal function was pristine and intact, and the average number of procedures was much reduced with auto-transplantation. So in select cases with stone disease, they actually do well, and this is basically their modified version of a Boari flap for bilateral and unilateral cases. So let's go to the heart of this talk, and it's auto-transplant for urethral injury or urethral strictures. So again, a lot of this data stems from the Cleveland Clinic in the era of Andrew Novick, who was a urologist with vascular training and was a pioneer in renal transplant and renal auto-transplantation. They presented the series over 14 years with 23 patients who had renal auto-transplantation for urethral disease. And you can see in the text here, a lot of them had pylovesicostomies, and very few had pyloureterostomy or conventional anastomotic technique. And the reason why I'm embarking on this is because you have to think of your lower tract as well when you're doing these cases, because you basically have no ureter. So you're relying on a healthy lower tract to anastomose this kidney, either direct renal pelvis to bladder or a flap to the renal pelvis. So they actually had a 91% kidney survival looking at these cases on a span of 1 to 14 years follow-up, and they lost 2 out of these grafts. So a lot of these patients did very well. So their success rate was pretty impressive. Again, this is a series of cases of around 50% of these cases were for urethral stricture and flank pain from stone disease, and these patients also did very well. But again, I'm trying to highlight there is a complication rate that you have to take with a grain of salt with these cases. So if you look at multiple case series for urethral indications, the success rate is pretty decent. It's above 85%. Most of them will reflux. Some of it is pathologic and some of it would be benign. The rate of graft loss is not that high, but the infectious complications that can occur with these cases are not that high compared to bowel segments. And really the main complication here is the vascular thrombosis that may happen secondary to infected or a mycotic pseudoaneurysm. So, in my personal experience, I have dealt with a lot of these cases related to renovascular indications. For urethral indications, it's been a handful. And I want to present this interesting case. So, this is a lady that came to me after having had 2 previous robotic pyeloplasties, 1 previous endopylotomy. She had normal renal function, but she had a PCN. She was miserable. She could not tolerate stents. She had multiple UTIs in the past couple of months before seeing me, and she had 2 admissions for urosepsis. So the only thing I could offer her in my armamentarium was to do an auto transplant based on my background. So I did a CT scan on this lady, and I could see a really good looking kidney, good parenchyma. She had 3 arteries and 1 vein, and she had a PCN in place. So I did a MAG3 just to have a baseline documentation, and she had good function, obviously, in this kidney and a small scar. And like I said, she had 3 multiple or complex vascular anatomy. I made sure the PCN was exchanged within 2 weeks of surgery, and her culture was sterile. So we proceeded with a open approach. So this was an intra-op picture, as you can see. I can zoom in closer. There's 1 large left renal vein and 3 renal arteries. This is the kidney after explanting it and trying to backtable it after flushing it with UW solution. And I basically had to cut above where the previous pyeloplasties and endopylotomies were. So I really had no ureter to deal with or to use. It was just really renal pelvis. And this was the end product. So an anastomose, 3 separate arteries onto the iliac system, and a psoas hitch for the bladder, and a pyelophysicostomy. And this was her cystogram at 4 weeks post surgery. So you could see it's intact anastomosis, but you can kind of right away think and look at this and think, if she doesn't empty her bladder very frequently, she is going to reflux and she is going to have problems. So thankfully, this patient was compliant and she was on a very strict regular voiding, double voiding. She didn't have any underlying dysfunction or any problems. I've had other 2 cases where I was able to do the nephrectomy laparoscopic and then extract the kidney through the Gibson incision where I did the transplant. So you can see there's 2 lap port incisions, and then the Gibson incision is just basically an extension of the lower port, and then that's where I do the auto transplant, whether it's right or left. In this modern era of minimally invasive surgery, doing it laparoscopically and auto-transplanting this open, or doing this completely intracarpulary robotically, you still have good outcomes, and the patients do extremely well if you do this after selecting the right patient. So in addition to this case I presented, I've had a personal experience of 6 other cases over the last 5 years, for specifically urethral stricture and trauma, 2 of which were secondary to urethral avulsion, 3 secondary to proximal stricture, secondary to stone disease and its sequelae of management, and 1 who had a gunshot wound in the mid-ureter and then subsequently months later was referred to my clinic. And I've lost 1 of these grafts secondary to thrombosis, and I had a patient with recurrent infections on suppressive antibiotics, which is most likely secondary to the reflux incurred. So the take-home message really, to do auto-transplantation for urethral stricture disease or urethral trauma, you have to really select your patients. So they do have a good long-term success based on literature dating back to the 70s. There is a risk of reflux that you have to accept and make sure that you have a good understanding of this patient's lower urinary tract before you do this. They do have a low rate of stricture or restricture because you do a very wide anastomosis, but there is a higher rate of vascular complications because of the area being chronically inflamed and chronically infected, and that's what's speculated by many. So If it's a less than 50-year-old patient, good renal unit function, there's no atherosclerotic disease, they're non-smokers, non-diabetics, you diligently treat the UTIs and make sure you have sterile equipment before surgery, you assess the lower tract, I think you can get a good outcome with these patients. And the approach is really up to your skill set and judgment, whether you do this open, laparoscopic, or robotic. Thank you very much.